Am I audible?
Yes, শোনা যাচ্ছে।
Assalamu alaikum everyone. My name is Anushi Arvin. I am a research fellow at the Bangladesh Institute of Innovative Health Research. Today I am going to discuss about a research paper. The title of the research article is Young Mothers' Attitudes Towards Domestic Violence and Their Maternal Healthcare Services Utilization in Bangladesh, a multi-level cluster analysis. At first, I am going to talk about the abstract of this research paper. The purpose of this paper is to scrutinize the association between young mothers' attitudes towards domestic violence and 4 or more antenatal care visits and health center-based delivery service utilization using 2 cross-sectional waves of the Bangladesh Demographic and Health Service 2014 and 2018 data. This study used a multi-level logistic regression analysis. Findings show that a strong cluster variation is present in 4 or more ANC and health center-based delivery service utilization. Although the utilization of 4 or more ANC and health center-based delivery services has increased over the years, it is far behind the targets of SDGs, particularly for young mothers with justified attitudes towards domestic violence. Extension of maternity allowance coverage and motivational programs are important for policy recommendations. Introduction. The utilization of 4 or more ANC and health center-based delivery care is an important WHO recommended strategy to reduce preventable maternal mortalities and their morbidities. Previous studies have identified several barriers of 4 or more ANC and health center-based delivery service utilization related to demographic and socioeconomic aspects of the population. Around 23.2% of women from wealthy countries and 37.7% women from South Asian countries, including Bangladesh, have experienced various forms of violence at different stages of their life cycle. Evidence also shows that in developing countries such as Bangladesh, miscarriage, preterm birth, stillbirth, low birth weight in newborns and maternal deaths followed by maternal morbidity are indirect consequences of domestic violence against women during pregnancy. Therefore, understanding the effects of domestic violence on young mothers 4 or more ANC and health center-based delivery service utilization is important for developing effective maternal healthcare policies and interventions. Materials and methods. Data source. The data are collected from Bangladesh Demographic and Health Survey 2014 and 2018 data. Data files for this survey are open to access and use through the DHS program website. With the permission of the major DHS, data from the recent 2 waves of Bangladesh Demographic and Health Service 2014 and 2018 were downloaded, merged, and analyzed. This study used children's data sets from each survey wave to extract the necessary variables, including in this study. Sampling design. The BDHS was implemented by a 2-stage stratified cluster sampling for the household survey. The sampling framework of this survey was developed using the total list of enumeration areas covering the entire country of the most recent census developed by the Bangladesh Bureau of Statistics. In the first stage, EAs were selected with probability proportional to the size of the EA. In the second stage, using a systemic sampling procedure, a certain number of households, on average 1 to 120, were selected from each EA with an equal probability. Ever married women aged 15 to 49 years were interviewed for this survey. The BDHS survey only included information on maternal healthcare services for women of the reproductive age group who had a live birth in 3 years preceding the survey. Study population. This study considered only currently married young mothers aged 15 to 24 years who had a recent live birth in 3 years preceding the survey. This allowed 2,431 observations from BDHS 2014 and 2,599 observations from BDHS 2018 after extracting and cleaning data available for the study. Variables characteristics, outcome variables. The study considered two binary outcome variables as indicators of maternal healthcare services utilization. The first outcome variable, utilization of 4 or more NC visits, categorized into two. Yes refers to those who had 4 or more NC visits, and no refers to those who took 0 to 3 NC visits. The second outcome variable is the place of delivery, which indicates whether the births were delivered at home or at a health center. If the birth took place at any health center, it is recorded as health center-based delivery, and if the birth was delivered at home, then it is recorded as home-based delivery. The independent variable of young mothers' favorable attitude toward domestic violence. A composite variable was also measured through young mothers' attitudes towards justification of wife beating or hitting by their husbands, which was grounded by their responses to 5 questions. If she burns the food, if she argues with her husband, if she goes out without telling husband, if she neglects the children, and if she refuses to have sexual intercourse with husband. This variable was coded into 2 categories for analysis purposes. Favorable refers to those who justify domestic violence with at least one of the above reasons, and 2, opposed refers to otherwise. A range of socio-economic and demographic variables was also included in the multivariate analysis. Region was coded into 7 divisions for BDHS 2014. Borishal, Chittagong, Dhaka, Khulna, Rajshahi, Rangpur, and Sylhet. Mymensingh was added as another administrative in BDHS 2018. Place of residence was coded into 2 categories, rural and urban. Household wealth index was coded into 3 categories, poor, middle, rich. Educational status of young mothers and their husbands was coded into 4 categories, no education, primary who completed grade 5, secondary who completed grade 10, and higher who attained above the secondary level education. Access to media was defined based on whether the respondents read newspapers or magazines, watched television, or listened to the radio. Thus, media exposure was classified into 2, yes and no. Young mothers' decision-making capacity was coded into 2, yes and no. If any respondent took part in making decisions solely or partially at least one of the issues related to own healthcare, key household purchases, and visiting her family members or relatives are categorized as yes in young mothers' autonomy variable and vice versa. The working status of mothers was categorized as employed and unemployed. Birth order was classified into 2, first birth and others. Statistical analysis. As the BDHS survey follows a 2-stage stratified cluster sampling procedure, the 2-level multi-level logistic model is used to examine the cluster effect among young mothers, and the random effect component is introduced for each cluster as the young mothers are nested into the clusters. The measures of association between 2 outcome variables and covariates are assessed through chi-square tests. The independent variables that were significantly associated with the outcome variables are included in the regression model. For each of the 2 outcome variables, 2 models are considered, a null model without any explanatory variables and a complete model with all covariates. Results. In table 1, it is shown that the percentage of young mothers with 4 or more ANC visits was increased by about 16%, 32.4% in 2014, and 48.3% in 2018. And health center-based delivery was increased by about 12%, 40.1% in 2014 and 51.7% in 2018 over the years. Young mothers' opposing attitudes towards domestic violence were also increased by 9.4% from 72.7% in 2014 to 82.1% in 2018. Moreover, young mothers' decision-making capacity was increased by 11.5%, and the proportion of employed young mothers was increased by about 15% between 2014 and 2018. The proportion of first birth orders was higher for young mothers in both years. However, in Table 2, the utilization rate was strikingly low for young mothers who had justified attitudes towards the reasons for domestic violence than those who had opposite attitudes, which indicates the negative effects of domestic violence on young mothers' utilization of 4 or more NC and health center-based delivery care. In Table 3, the percentage distribution of young mothers who received 4 or more ANC and health center-based delivery care by demographic and socioeconomic characteristics of the respondents is presented. Young mothers who had favorable attitudes towards domestic violence were significantly less likely to utilize 4 or more ANC compared to their counterparts who had opposed attitudes, particularly in 2018, and the p-value is less than 0.001. Between 2014 and 2018, the utilization rate of 4 or more ANC visits was increased by 10.5% among young mothers who had favorable attitudes towards domestic violence. In terms of using health center-based delivery services, Sylhet division had been identified as a low-performing area of all divisions for both of the study points, 24.3% and 42.8% respectively between in 2014 to 2018 respectively. Poor young women were less likely to use 4 or more ANC and health facility-based delivery care than rich young women. While young mothers from all subclasses of education were experienced a greater use of 4 or more ANC and health center-based delivery care between 2014 and 2018, the lowest increase occurred among young mothers with no education, 8.3% and 4.5% respectively. In Table 4, we can see the adjusted odds ratio and p-values using the data BDHS 2014 and BDHS 2018. From the adjusted covariates, the lower utilization of health care facilities for antenatal and delivery care was found to be associated with young mothers' favorable attitudes towards domestic violence in both of the survey years. More specifically, young mothers who had a favorable attitude towards domestic violence had 33.2% lower odds of getting health center-based delivery care in 2014, whereas the odds was lowered by 19.7% in 2018. This table also reported the cluster effect on maternal healthcare services based on the random effect for both of the survey years. Firstly, a separate null model was applied for each of the outcome variables to check whether the application of multi-level logistic model in this study is justified. The result shows cluster variances for both outcome variables. 24% of total variation was found in receiving 4 or more ANC in 2018 data. Discussion. This study demonstrates that young mothers who have favorable attitudes towards domestic violence were less likely to utilize 4 or more ANC and health center-based delivery care than those who had the opposite attitudes. In Bangladesh, women's favorable attitude towards domestic violence is associated with their inferior social position, inferiority, negligence, poor educational status, lower sense of entitlement, lack of self-esteem, and lack of awareness. Moreover, this study finds the presence of cluster variation in the utilization of 4 or more ANC and health center-based delivery care for both of the surveyors. Young mothers from disadvantaged communities have inadequate utilization of 4 or more ANC and health center-based delivery care. Rural young mothers are less likely to utilize 4 or more ANC and health center-based delivery care compared to urban mothers, which is considered with earlier studies. The utilization rate of 4 or more ANC among young mothers of the Sylhet division has increased remarkably in 2018, which was previously identified as low-performing division in terms of using ANC visits. Poor young mothers are less likely to use 4 or more ANC and health center-based delivery care compared to rich young mothers in both survey periods. The utilization of 4 or more ANC and health center-based delivery care are associated with young mothers' education and their husbands' education, which are identical to earlier studies conducted in Bangladesh. Mass media exposure also contributes to increasing young mothers' utilization of 4 or more ANC and health center-based delivery care, which is also reported in previous studies. Surprisingly, employed young mothers in our study are found less likely to utilize 4 or more ANC and health center-based delivery in both of the survey years. Despite being employed, Bangladeshi young women have limited liberty to exercise their own decision and ability to spend money on their healthcare. Furthermore, employed young mothers sometimes feel uncomfortable using these services due to shyness and family restrictions. Young mothers with first pregnancies are more likely to utilize those services compared to their other births. Conclusions. The findings of the study demonstrate that young mothers with favorable attitudes towards domestic violence are less likely to use 4 or more ANC and health center-based delivery care than mothers with opposite attitudes. A strong variation in the clusters, which is identified in our study, is also associated with lower utilization of 4 or more ANC and health center-based delivery care. Considering the variation among clusters, the coverage of the maternity allowance program should be extended for universal maternal healthcare coverage in Bangladesh. Findings suggest that there is a scope for further study to identify the cluster variations considering the community level features and extend the analysis to a 3-level multi-level analysis. So these are the some references mentioned in this presentation. Thank you. Any questions? Thank you, everyone.